Hello, welcome to Sexuality and Ovarian Cancer. We're going to wait for a couple minutes for folks to get signed on. It sometimes takes a few minutes to get through the login process, so as folks sign on, we'll just be on hold here. So the title of the presentation today is Sexuality and Ovarian Cancer, but we know a lot of the folks, the participants in our programs for breast cancer are also interested in this topic, so we're glad to welcome them. I think there'll be a lot of crossover information. But yeah, so we're going to still wait just a couple minutes for people to get logged on. Okay, we're still going to wait just a minute or two more for folks to log in. Okay, I'm going to go ahead and get started. So welcome to Sexuality and Ovarian Cancer. I'm Stephanie Blaufarb. I'm the Ovarian Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast and ovarian cancer for the last 42 years by offering the support of those who have been there. SHARE offers many services, including a helpline, telephone and in-person support groups, and educational programs. And many of these are specifically for those living with ovarian cancer or breast cancer or metastatic breast cancer. All of our services are free of charge. For more information, visit our website at sharecancersupport.org. All participants will be muted during the presentation. When the presenter finishes speaking, we will open up for a questions and answer session. You're welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. So now to introduce our speaker, Victor Hola is a registered nurse with a bachelor's in education, an associate's in nursing, and a certification in sexual counseling and sexual education. He is certified with the American Association of Sexual Educators, Counselors, and Therapists, and has been at the University of Michigan Hospital System since 1999. He's also a public speaker for the Women's Foundation for Ovarian Cancer and a pharmaceutical company. Without further delay, I'm happy to welcome our speaker.
Thank you. I cannot speak more highly of SHARE, this organization, so please avail yourself to this organization, and I am very honored to speak for them. So, as a nurse, it is very different than a doctor. A doctor can work with the illness, such as ovarian cancer or breast cancer, and the nurse will address those symptoms, maybe there's skin issues or irritation. So that is the difference. The nurse does not diagnose. So let me, the Kinsey study was a very interesting study that they had with human sexuality. And they were talking about erections, and oftentimes someone, if a man is having difficulty obtaining an erection, he will then start to pull away from the partner because he is afraid that he can't finish what he starts. So this can also spill over into the partner. So the reason why I like this picture so much is when you're having sexual activity, it doesn't have to always go all the way to orgasm. This picture, I don't know what it is, but I imagine they're getting ready for bed. They just brush their teeth. One of them starts to hum a song. They start to dance, and maybe that dance just lasts 15 seconds, 30 seconds, and they get into bed. And that's all there was. Well, that is great sex. And the reason why that is great sex is because they are not living as roommates. They are living as sexual partners, even though they're not having sexual activity right at that moment. So sometimes when a woman is going through ovarian cancer, breast cancer, or any of the cancers that are female in nature, there can be a tendency to start living as roommates over time. It can start out very innocent in stating, well, once I get over this sickness, once I get over chemotherapy, things will return to normal. That can be a very dangerous road because returning to normal can take forever. There's always tomorrow. So I encourage you, even during treatment, to not live as roommates and to live as these two people are. Just dance for 15 seconds if that's all you can do, but it's not as roommates. Sexual desire, energy level changes during times of treatment, and it can change post-treatment. It can change even before there is a diagnosis of a cancer, because you may not be aware of what is going on, either vaginally, pelvically, or with the breast. Sexual desires. When it comes to sexual desires, sometimes it is changed by the way we feel about ourselves. The partner may not be feeling that at all, but we project our own image of how we feel about ourselves onto the partner, thinking they must feel the same way. They can't possibly be blind. Of course they're not. Oftentimes that's a big mistake. So sometimes it just helps to ask, how do you really see me? Sexual desire is affected by lots of things, but stress, fatigue, low desire, and those are hard to qualify in a clinic setting. When you are in front of the clinician, the doctor, and you're speaking about low sexual desire, it's hard to rate it from 1 to 10. How much stress did you have at work, or fatigue, or how sometimes I feel like starting sex and then 2-3 minutes into sexual activity, I'm no longer there for some reason. So those are hard to quantify in hard numbers or scales. Women who have had surgery, pelvic or abdominal, this can make sexual intercourse difficult. Even if the vagina is well lubricated, it's healthy, you have no pain vaginally, there's no dryness, but the position that you're in, whether you're on top or you're on bottom, those can be difficult positions to get into if you've had any type of abdominal surgery. These are my references, so I'm not going to ask you to read them now, but this slide presentation is available, so should you wish to look any of those up, those are all available for you. So those women who have signed in and are having sexual activity with men, I'll address those first. Men are more likely to orgasm when sex includes vaginal intercourse. So what does that mean for a woman with a lot of vaginal pain or vaginal dryness? That's kind of a double baggage for a woman to carry around. That's a big rock on her back to carry. There can be conflicting feelings of, I want to have sexual activity with this person that I love, but it's painful. And so half of me is saying no, half of me is saying yes. Another part is, even though this is painful, it is a form of intimacy that I enjoy, and I want to experience that person's body next to mine in an intimate way. And so how do I address that if I'm having a lot of vaginal pain with any type of penetration? And this can also go for anal penetration too. I don't want to just be very narrow in my thinking there. Women are more likely to orgasm when they engage in a variety of sexual activities during the sexual activity, whether it's vaginal intercourse, clitoral stimulation, stimulation of the breast, or whatever your particular erogenous zone is. It could be your left elbow that really triggers things for you, and you have to be made, the more you're aware of yourself, the more you can help your partner give you personal satisfaction. This is another picture I like, and there's an enormous range of sexual activity for adults. And in one survey has it up to 40 combinations of sexual activity. This couple, again, is having great sex because they're inhibited, not inhibited, they're uninhibited. This may be all there is to that sexual activity. The woman goes back to picking up another dish in a few seconds, or it could lead to full sexual activity, both of them turning towards each other and be caught up in the moment. But what I like about this is it doesn't always have to be constricted. It doesn't always have to be in the bedroom with our clothes off. It doesn't always have to be when we're feeling sexy. It can be just as you are where you are. That's the important thing. So 85% of men report that their partner had an orgasm at the most recent sexual event. But only 64% of women reported that. So there's a discrepancy there. And the closer we close that discrepancy, the better sex can be for a couple. Even if that couple is only 3 weeks old, maybe you met someone after leaving chemotherapy in the elevator. I can't tell you how many times it has happened in our hospital. Someone saying, I'm not interested in sexual activity anymore. Those days are gone. I'm 75. I'm done. And then they meet someone in the elevator leaving. So, does it happen every day? No, it doesn't happen every day. But if you are open to it happening, the chances increase. So with sexual activity, right after we kind of peak at age 17, a little different for men, a little different for women, but then it can start to go downhill. And one of the big reasons is that chair right there. So you need to stay physically active. You need to stay engaged. You need to stay, I want to be here on this planet, right here, right now, on this particular time, with this particular person, and feeling those feelings that I'm feeling right now. This is another slide of great sex. Betty White is baking a cake, she's frosting it, and she's offering the spatula to the UPS guy who just forgot to wear a shirt that day for the first time. And it's great sex. No one's jumping on the counter like they do in the movies. No one, the band isn't playing, and that's all there is to it. Sometimes that can be great sex, and it can be the prelude to great sex. Good health, the way we treat ourselves physically, emotionally, the way we treat ourselves psychologically, spiritually, is important. It all equals good sex. So that's good health equals good sex. It's hard to have good sex if you're having problems moving. If yoga is difficult for you for some positions, sex may be difficult for you for some positions. Weight is important. I'm not saying an overweight person cannot have sexual activity. They should. And I've talked about body image, how important body image is. So this slide, some people may say, oh, he's making fun of an overweight person. I'm not. What I'm saying is, one, I'm glad they are comfortable in their bodies, that sexual activity is important for them. Two, I'm concerned on a health level. I want them to be there tomorrow. And that much weight can be difficult for good health. But it also goes to our BMI, how we feel about ourselves. There's one woman listening right now, or will be listening in months to come on one of these slides, that has urine leakage. And sometimes it's not addressed. Any type of urine, this particular woman, whoever you are, may feel inhibited to have sexual activity because, is my sexual partner going to smell urine? Am I going to be leaking urine right before penetration or at penetration or at clitoral stimulation without any penetration? Will I be leaking urine if I cough or I sneeze? Or let's say, will I be leaking urine if I start to laugh, maybe during foreplay, the half hour before? And so if all of those answers, or some of those answers are yes, roadblocks start to appear before getting into sexual activity. And you may find yourself withdrawing. Maybe I shouldn't have sexual activity. Some things you can do, two things you can do, Kegel exercises, pelvic floor exercises. You can also not have drink or fluid intake roughly 2 hours before sexual activity. We don't always know when sexual activity is, but if you are doing those and you are still leaking, I urge you to see the doctor. Urine leaking is not normal. You should be 95, 96 and not leaking, and then when they finally put you in the coffin, you should be going in that coffin dry. You should not be wet. So don't settle for this is normal, a couple drops. It is not. There's a couple now in the audience that hopefully this remapping will work for. Whether that couple is a straight couple, a gay couple, transgender couple, or a couple that some people don't like to talk about, but it's the couple of me and myself. There's some people who are single and are comfortable being single, and that's good, and that's okay. I still would like you to do this remapping, even if you are on your own. So remapping is, we are going to learn our bodies all over again. If you've been in a relationship for a few years, or even, let's say, 40 or 50 years, when you're having sexual activity, part of you is having sex with the person that you met at the beginning, and part of you is having sex with the person, that body now. We have to bring those two together. This is a 4-week exercise. Week 1, I want you to lie on the bed, on your back, completely naked. The partner is then going to start at your toes, work all the way up to your head. That partner only has 10 minutes. If it becomes sexual, at any time you stop. It is not sexual. And I'm going to demonstrate on my hand how to do it. So you'll say, oh, the partner is going, this is your hand, this is your wrist, this is your arm, this is your elbow. And you're going to say, boy, I hate when you touch my elbow. I don't know why you think that's so sexy, but it hurts me. I have arthritis there, and I've never told you because you think it's sexy, but it really hurts. Please don't touch it again. Your partner will say, well, you never told me that. We've been making love like this for 40 years. Why didn't you tell me? Well, you never wind up telling the person you're most intimate with your most intimate things. That's how life is sometimes. So then you go here, and you go, and your partner will say, and that's your breast. And you may say, can't you call it a dirty term, like maybe boobs or tits or something? Or maybe the partner is saying boobs, and you would say, can you just call it a breast? And I don't have breasts anymore. They've been surgically removed. I've had a double mastectomy. I don't know what name I want to name this, but I'm not comfortable with boobs right now. So we're just not going to name it right now. And that's okay. It's okay. So you're going to rename the whole body. That person's going to learn your body now. Week 2, the partner's on the bed, naked, and they're on their back. And you're going to go over the whole body. And you're going to do the same thing with certain parts. And that partner will tell you, I prefer a dirty term. I don't like when you call it a nice term, or vice versa. You're going to learn each other. Week 3, you are on your stomach. Do the same thing. Week 4, the partner is on their stomach. I guarantee you something will happen one of those 3 weeks where you will either start to laugh or you'll cry. You'll realize something you didn't know about the other person. And that's healthy. Information is healthy as long as it's truthful. So this is the time to be truthful, okay? I'm putting on my glasses to see the time. So if the moderator could give me like a 10-minute warning, okay? When I should stop talking. The women's sexual issue after cancer treatment, and for men too, you have desire, arousal, orgasm, refractory period. Now, this particular diagram is more for the men. Men tend to be linear. They have a desire, they get aroused, they have an orgasm, refractory period. The women is a lot more, it actually looks more like a plate of spaghetti. Okay, there's a lot of crosses, and it may start with arousal and go slightly towards orgasm and then desire, and that's normal. And every woman is normal. And every time you have sexual activity, it may be different. That is normal. Okay? Number 2, under arousal, the older we get, there's a saying, more friction and more fiction. Maybe I once was counseling a couple in their, they were both about 95, 96, and they came to see me for sexual counseling, and what impressed me was they were no longer comfortable with sexual activity because of arthritis and stuff, but they said, what else can we do? And so I remember from one of my courses, they could read erotic poetry to each other. And that's what I prescribed. And it turned out to be a good thing. So we don't always have to stop what we're doing. So maybe more fiction you can introduce. And sometimes it's more friction, sometimes it does take longer to orgasm. There is a woman listening now or in the future that the labia, after probably radiation therapy for the vulva, that becomes very, very angry. Sometimes it almost starts to look like tissue paper. It is friable. It hurts. These women don't even want to put on underwear. They don't want to shower because it hurts. It hurts to urinate. All of these things. This product I want to introduce to you, the Aloe Vesta, it is used in the burn units so that if all of it is not wiped off, and obviously they can't take a washcloth and scrape it off because of the burn skin, it's okay if it's not all wiped off. So I want to introduce you to that. The reason I'm introducing that to you, because if we don't get that vulva back to where it's normal and pleasurable, sexual activity is not going to happen, even if the partner says, well, what about anal sexual activity or just having oral sex? Well, if you're not feeling good and comfortable and you're in pain, it's not going to be enjoyable. So that's why I bring this product to you. For the woman who has stopped some sexual activity and wants to gently get back in, I think this is the best thing out there. I'd like you to get this. It's about the size of a banana, and it's curved like that. So I'd like you to start using it on your shoulder when you're watching TV, and just give yourself a massage. Then that may gradually go to your partner, maybe doing your partner's shoulder. Just getting used to the touch of someone else. And gradually that may wind up maybe on your legs or down your back or towards the groin. Gradually. It's a great product. I also tell them, keep it on the end table when you're watching TV. When the grandkids come over, let them play with it. So what? It's only a battery. If they run out, so what? Let them give each other a massage. The grandkids don't have to know that it's a sexual tool. If they're in their teens, you can tell them. It's your choice. But this way, it's there and you'll use it. If it's on the nightstand, in the drawer, it's not going to get used. Maybe once or twice, and then that's it. So I'd like it on the end table when you're watching TV. And treat yourself to a massage. It's just a good product. You'll like it. Wands, vibrators. They come in all shapes, sizes. All of you have heard the term rabbit. All of these are good. The one that works the best is probably the third or fourth one you buy. Law of averages, okay? So don't be afraid of trying one or two or three. It's okay. Not everything you eat in a restaurant is perfect. If you order something off the menu, you still may go back to that same restaurant because, all right, we can try that again. And it's the same with vibrators or sexual stimulation. So if you're going to have sexual activity, maybe a massage is what you need to prepare yourself to do that. If you're just finishing chemotherapy or surgery or radiation, maybe just the thought of another person touching you, you're not there yet. If it's in a sexual way, you're just not there. But maybe a very gentle massage, maybe for 10 minutes by someone else, just to get you used to that, is what you need. So allow yourself to do that. Sometimes we inhibit ourselves so much, thinking, well, I don't deserve that. Well, yes, you do. Yes, you do. Well, let me get back to deserving. Nobody deserves anything in life. But I think we can treat ourselves to that. I prefer treat rather than deserve. So dilators. We used to recommend the set, this set with the white ones from Vaginismus. The reason I liked them is because they had this applicator. The gray applicator could be attached to the dilator when you're doing dilation vaginally. As we get older, it may be harder to, if you're sitting on the bed or lying or reclining, it may be hard to reach the vagina, either because there may be some weight issues or some large thighs, or you may be thin as a rail, but you have arthritis and it's hard to move your hand that way. Whatever the case, you want something a little longer and not short. We no longer recommend these because these are hard plastic, and once the dilation therapy is ended, I don't know any woman who is going to use this for sexual pleasure, for sexual stimulation. So a better product are these. I have these here so you can see. They're soft, they're pliable, they're antimicrobial. You can wash them. They don't carry germs with them after washing. They're long enough so that you can reach the vagina. Now, I'd like to show you how to use dilator therapy if your doctor recommends that for you. Let's say this is the vagina. You're going to place this, well, first of all, you always want to do dilator therapy in a room alone. Not that your partner can't be there, but human beings are human beings, and it can become sexual very quickly. And I want you to concentrate on dilator therapy. So, let's say this is the vagina. You're going to take the smallest one that you feel comfortable with, place it against the vagina. You want to lubricate inside the vagina, the outside of the vagina, and the entire labia. And if that is as far in as you can get the very first week or month, that's fine. It's not the vagina Olympics. So the goal is to have the entire dilator resting comfortably for 10 minutes. Then you can move to the next size up. With dilator therapy, you should talk to your doctor about this, depending on what your diagnosis is. But it can help with some vaginal dryness because it can make the walls of the vagina more supple. Remember, the vagina is like our lips. They're muscular tissue. So you have to exercise that muscle. The more you exercise that muscle, the more lubrication you have, and vice versa. It's kind of like chicken and an egg. But not all vaginal dryness is due to that, though, as I will address with some medications. So this is a very good product. The company is, you can see on the pink one, it's called youandmetime.com. I can't recommend them highly enough in that when you call, you get an adult. It's not some teenager giggling over why do you want dilators. I have this company in high regard. They do a lot of medical equipment, such as the helmets for small babies with misformed heads. So they have a medical bent to all of their products. They actually have a doctor on staff. Clitoral pumps. Think of this like a cane. A cane is not going to walk for you. A cane is going to help you walk. A clitoral pump is not going to have an orgasm for you. It will bring the blood supply to the clitoris for stimulation for you to have your orgasm. So a small cup is placed on the clitoral, head. This is a pump. It will cause a vacuum. Then this twists, and the twisting will start the battery in a vibration. There's a lot of different heads you can get. There's a lot of clitoral pumps you can get. There's all kinds out there. I would say experiment, find the one you like. In surveys, more women prefer clitoral stimulation rather than vaginal stimulation for an orgasm. And there's no reason why you can't use a clitoral pump during sexual activity with a partner for that.
Hold on, I just wanted to, you asked for a 10-minute warning, so I want to give you a 10-minute warning. In 10 minutes, we should move to the Q&A part.
Perfect. There is one product you all have the slides, so you can go through the slides, but one product that came on our radar is called Intra Rosa, INTRAROSA. It is not in the slides. Intra Rosa is a new medication. It's by prescription for vaginal dryness. I think this particular product is going to be big in the upcoming years. Not only is it for vaginal dryness, helping for sexual activity, but a nice side effect of this is that the medication will lower the pH in the vagina, in the vaginal vault. When that happens, the secretions that come from the vagina oftentimes will travel to the urethra. And it can be micro secretions. You may not even be aware your underwear isn't stained or anything. But that pH balance is lower, and thus it is not causing a UTI. I guarantee you, out in the listening audience, there's a woman who is having recurrent UTIs, and that could be the reason. Is it the reason? I don't know. I'm not a doctor, and I don't want to give that diagnosis, but that's the reason. But I think this product it's not a product, it's a medication. I think this medication could be a lifesaver for a lot of women with recurrent UTIs. The other benefit is a healthy vagina. You should have a healthy vagina into your 90s and having sexual activity if you have a partner into your 90s. Or if you're not having to have healthy self-stimulation for self-orgasms, if you have vaginal orgasms. So also, if for nothing else, when you're in the old age home and they say, Mrs. Smith, it's time for you to go for your vaginal exam, you're going to say, well, I really don't like to go, but at least it doesn't hurt. And all the other women are going to be complaining because it hurts, because that vaginal vault is not healthy. So I can't recommend this medication enough. I really do think it's going to be a lifesaver for a lot of women. Anyway, getting back to the next slide, the Oh My Bod is a great product. You pick your favorite song, you sync it to your iPod, and then the vibrations are in the vibrator, and so whatever that favorite song is, it is going with the vibrator. I just think why shouldn't you have two senses going, your hearing and the sexual. On these slides, you'll see a lot of products. Some work great, some not as well. Um, but lubricant is important for sexual activity. Lubricants can make or break the game in a lot of sexual activity. If it's a straight couple, most men really don't care what's on their penis. But women, it could be, it doesn't smell right. I don't like the way it feels. I can't feel the dilator, or I can't feel a finger during sexual activity. It's too much lubrication, or it's not enough. It's too dry. It's too slippery. I feel itchy the next day. So if you go through 3 or 4 lubricants until you find the right one, it is well worth it. Well worth it. If you can't find anything, coconut oil in the store, you can get a big tub for $7. Usually works for a lot of people. Olive oil has been known to work for a tiny fraction of women that have severe vaginal dryness, and lubricants just don't seem to work. Oil does. Olive oil does. Vaseline, no. All the jokes from the 70s, no. It's good for feet. It is not good for sex. These are all your moisturizers. Vaginal estrogen has lower side effects. New studies are coming out about women with breast cancer. You know, there was that big study with, I can't remember the percentage of, should not be using estrogen products if you've had breast cancer. Well, it was the same percentage in the national population. So the study, when we go back and look at that study, there's some things that are throwing us concern. So that is being reevaluated. This is the thing on women's desire. I'm going to race ahead a little bit here to G-spot. My feeling about the G-spot is whatever turns you on and makes you excited is the G-spot. This is the traditional G-spot. Not all women have a G-spot. Some women's G-spot is a piece of chocolate. And if that's your G-spot, that's good. That's healthy. Try and find your own G-spot. And sex may change, but it will never die. You will have the desire for sex for as long as you are alive. Okay, I will take questions.
Hi, okay. So thank you so much for this. All this information has been great. We had some questions that were submitted in advance, but also I want to remind folks that are listening that if you go to the webinar panels there's a little drop-down tab that says questions, and you could submit questions there, and I'll read them out. So our first question that was submitted, this person references a clinical trial. They don't mention the clinical trial, but they say they saw a recent clinical trial that found that over-the-counter moisturizers can be as effective for dryness and pain during intercourse as estradiol. I'm not sure if I pronounced that right, estradiol. But yeah, what do you think about that?
It depends on if you're just using the like Astroglide or any one of those lubricants for sexual activity, then yes. So you want to make sure you lubricate the vagina, the entrance to the vagina, the entire labia, and what is ever being inserted, whether it's a finger, whether it's a penis, or it's a dilator. Now, you are saying, can I use these lubricants on a daily basis? I think that's where this question is headed, but I'm not sure. I don't know. I don't know that study.
Okay. So this person says, besides intravaginal estrogen and lots of lube, are there any other tips for managing vaginal atrophy associated with tamoxifen?
Not that I'm aware of, and not that I'm aware of. It doesn't mean that they're not out there. I'm just not aware of them.
Or what about in general for vaginal atrophy? Not just for tamoxifen, but other than lube and estrogen, is there any other things you would suggest?
The only thing that I'm really aware of is the few things that I mentioned. You can do dilator therapy a couple times a week. That does help the vaginal walls. There is a study a few years ago with women who had severe vaginal dryness from radiation. They used a clitoral pump for 10-15 minutes 3 times a week. That brought back vaginal atrophy and the lubrication. I think this new medication, Intra Rosa, can address some of that.
Okay.
But that's all I know. I don't want to pretend I know something I don't.
Okay, that sounds good. This is sort of a general question, and you went over a lot of this in your presentation, but this person submitted this question. What are recommendations to improve sexual relations post-chemo, hysterectomy, post-menopause for folks who've had ovarian cancer diagnosis?
Oftentimes, that woman with that diagnosis will have a lower libido, whether it's self-imposed or it's due to some of the hormone changes. I would suggest getting out a calendar in a non-threatening way with your sexual partner, with a glass of wine or coffee. If you don't drink, have coffee together, and mark on the calendar 3 or 4 sexual dates. So let's say it's Thursday, 7 o'clock. Well, Wednesday, you're going to send that partner card, or buy that partner some new underwear because the current stuff is pretty ratty. Have your partner remind you of the sexual date. Maybe you need water aerobics to get loosened up. Maybe you need your pain medication 2 hours before sexual activity. Let's say you are someone who is having sexual activity on top. Can your knees bend in that position? Or, yeah, they can bend, but I need my arthritis pain before I do that. So if you have a definite date and a definite time, you can get yourself there. Do you have urinary incontinence? Well, you may want to stop drinking a few hours before, so you're addressing that issue. You need a definite date and a definite time. Also, the older we get, and I'm going to guess if this woman had a hysterectomy, she's over 40. The older we get, anticipation works better than, I want it right here, right now on the kitchen counter. I've been married 27 years. I pretty much know it's not on the kitchen counter anymore, but I pretty much know it's Thursday night if I play my cards right, okay? So I get ready for Thursday night by doing what I need to get there. And so get yourself ready for whatever Thursday night at 7, if that's your time, okay?
Okay.
I don't know.
So
Does that help?
this, yeah, I think that that's good advice. That's good. That's good. Um, so this next person seems very frustrated. I'm assuming is somebody who's had an ovarian cancer diagnosis and treatment, and she says, "Will my vagina ever recover? I can't have vaginal intercourse. The last time was July 2016." So, any advice for someone who feels like they can't have vaginal intercourse?
Um, it. I'm going to go down the road of not really knowing what has. I don't know what treatment she had. Has she had surgery, radiation, or chemotherapy? So that those are all factors on what's happening inside the vagina. If the vagina is just, I don't want to say just, but if the vagina is closing in and there's some stenosis, sometimes if there can be almost like these little striations, little strings, and it can start to close up. It could be just a question of dilator therapy. And if it's been 2 years, it can be a long, slow process to get that vagina back to where some type of penetration can happen. If surgically that vagina was altered, it was maybe shortened, something was done with the cervix, maybe there was something, maybe a tumor on the side of the vagina, so the vagina needed to be altered surgically, that's a different story. I can't address that without knowing her particular anatomy. But if all of those things are okay, then I would start dilator therapy with the doctor, like I showed.
Okay. Um, so our last question, unless anybody wants to submit a last minute question, is scars can impact our self-image. Is there any way to reduce the look of long scars from a debulking surgery or something to do with our cancer diagnosis, or to feel better about that?
Yes. I'm going to tell you what you already know. Those vitamin E capsules on top of the scar, just open up one a day. It works miracles. There's nothing better, and don't buy any expensive scar cream or anything. Just get the regular CVS or Walgreens brand or whatever. If you have a partner and the scar involves sexual activity, doing the remapping can help. Labeling the scar, saying, I don't like my scar to be touched, I want my scar to be touched. It's often scars can have a hyper sensitivity, and it's not in a good way. Sometimes those scars are like right in the middle. I don't know if I want to laugh right now or cry. It's a very odd feeling. Nerves take so long to regenerate. And you can have those feelings for a long time. I think she's more concerned with how she feels and looks about that scar. It can be difficult. Are you seeing a plastic surgeon for scar renewal? Most plastic surgeons probably charge around $100 for a consultation. It may be worth $100 to, I want this evaluated. What are my options? I'm worrying about this, but I really don't know what my options are. Can they pretty much get rid of this for me? So information is power. Those would be my 3 things to suggest.
Okay, great. Well, thank you so much for this really informative program and for answering our questions. And thank you to everybody who participated. Please if you could take a moment to fill out the survey at the end of the webinar. After we end the webinar here, it'll take a minute for that to pop up. Yeah, so I just want to say thanks to everybody.
And thank you. It was quite an honor to be with you today.
Oh, we're so glad to have you.